This short video will introduce you to the new communication, sleep hygiene and delirium resources on ITU and how you can use them to support your patients. About a third of patients on ITU will have difficulties communicating. Communication difficulties can be caused by various things: a primary medical condition such as brain injury or stroke, or it may be due to an ITU intervention itself, e.g. an ET tube or cuff tracheostomy, sedation, critical care weakness or delirium. Other things like pre-existing mental health or learning difficulties, visual and hearing impairments, or a language barrier also impacts on a patient's communication. Research has shown that ITU patients with communication difficulties report feelings of frustration, powerlessness and anger, and are at an increased risk of developing post-traumatic stress disorder. Similarly, nurses have also reported feelings of powerlessness and frustration when caring for this patient group. GPIC's guidance states that patients must be given help to communicate and must be effectively communicated with. There are also national competency frameworks for both nurses and AHPs working in critical care that specifically outline addressing the communication needs of patients. Since COVID, the resources on ITU, like whiteboards and alphabet charts, have significantly diminished and many are no longer appropriate. We are launching some new low-tech resources and a simple flowchart that will help you choose and use the right communication tool for the right patient. All the communication resources are housed in a new communication station trolley in Pod C. Work through the flowchart on the top of the trolley to help you decide what to try first. Step 1. This is just a reminder about some simple things that can make a big difference: checking glasses or hearing aids. Step 2. Use the flowchart to consider A, your patient's language or cognitive status, and B, your patient's upper limb function. Then go to the numbered and coloured drawer to find the appropriate resources. For instance, if your patient has good cognition and language and good upper limb function, go to drawer 1. Here you'll find whiteboards and pens, boogie boards, and information sheets about free apps that patients or their families can download onto their own devices. If your patient has good cognition but poor upper limb function that makes writing difficult, then go to drawer 2. Here there are picture and phrase charts to point to and partner-assisted alphabet charts. You can scan the QR code here to watch a short video about using partner-assisted scanning. If your patient has poor cognition but good upper limb function, go to drawer 3 to find a yes-no chart and simple picture chart. If your patient has poor cognition and poor upper limb function, then picture charts or whiteboards will not be suitable. Go to drawer 4 to find some helpful tips on supporting communication and consider completing a This Is Me profile. Step 3. Refer to SLT on dashboard. We can chat to you about what has worked so far and offer any specialist advice or support. The SLTs and ITU therapy assistant will be ensuring the trolley is kept stocked. Please return any resources to the trolley so we can clean them and put them back in the drawers. Delirium can be defined as a disturbance of consciousness, attention, cognition and perception, which develops over a short period of time and tends to fluctuate throughout the day. Delirium can often be confused with other conditions like dementia or sometimes depression. Unlike dementia, delirium develops quickly and is usually temporary, lasting for a few days to weeks and in some cases months. Delirium can present in 3 main ways: hypoactive, hyperactive and mixed. Hypoactive delirium tends to make a person withdrawn, drowsy and quiet. Symptoms can include poor concentration, slowed speech, reduced mobility or movement. Hyperactive delirium can make a person agitated, restless and sometimes aggressive. Symptoms can include delusions, hallucinations, sleep disturbance or impulsive. Mixed delirium occurs when the person moves between these 2 types. Up to 74% of patients may be affected by delirium within critical care, and this is often underdiagnosed. It has been linked to long-term cognitive impairment, increased mortality, and significant strain on patients, families, and healthcare staff. The intensive care population faces many challenges to establish a pattern of natural and restorative sleep. It is reasonable to assume that when a patient is taken off sedation, they have had very little functional sleep during the whole period that they have been sedated. In addition to this, they are not in their own environment. They are repeatedly woken by alarms or interventions such as monitoring or turning and repositioning. Time taken to sleep becomes prolonged. Sleep is fragmented and is often limited to lighter stages. There is a relative lack of time in restorative deep sleep. Changes in normal routines and disruptions in sleep can also lead to delirium. GPIC's guidance states that as an MDT, we must provide non-pharmacological strategies to prevent and reduce delirium. The delirium and sleep hygiene trolley is also found in Pod C next to the communication station. The trolley includes various aids to support those experiencing delirium and to also help with prevention or worsening of symptoms. It includes aids to promote quality sleep. These include orientation logs and charts, digital clocks, earplugs and eye masks, information booklets, patient sleeping signs, This Is Me document, list of familiar items that families or friends can bring from home, and a prompt sheet on normal sleep pattern. If you have any questions, feedback, or would like to get involved in our projects, speak to a member of the ITU Speech and Language Therapy or Occupational Therapy teams. Alternatively, you can email Charlotte at the below address. Thanks for watching.